I'm looking forward to talking through exactly as Walter described how the Ottawa Methods Center in particular might be alongside my colleagues from Craner, another resource that you might be currently drawing from or could draw from more in the future in supporting your work. And what I want to make the case for is really that Ottawa and the Ottawa Methods Center in particular really provides expertise for each gear in the learning health system, and can operate, and we operate very much as a hub for that type of expertise, not only within gears but across these gears. And I'll give you a couple of specific examples of how we try to connect make those connections. So the Ottawa Methods Center really, I hope if you don't know about us, that you see it very much as an infrastructure that you can draw from. It was established in 2006, but now includes over 30 methodological specialists that span 9 different specialty areas, which I'll talk about in a couple of minutes. And the types of clients that we serve within the Method Center include the scientists and clinicians, trainees, students, and researchers, but also government and healthcare organizations more generally as well. And so we like to see ourselves as very much a methodological one-stop shop for engaging in multiple processes across the learning health system. Okay, so in terms of what we do, and I mentioned we have sort of 9 areas of specialty focus. So on the left-hand side, it's sort of cross LHS perspectives in really design, methodology, data management, backend, and outputs and publication. But then the center column and the column on the right is really the core of the gears. So we have expertise in knowledge synthesis, in big data analytics. So when we're talking about data linkage, ICS data, or down to more specific biostatistics expertise, have health economics expertise, patient-oriented research, as well as knowledge translation and implementation science, which I'll talk about in a bit more detail. So as I mentioned, we very much see the expertise that we can provide and in partnership with yourselves as fitting into all the gears of the learning health system. And I wanted to walk you through a couple of examples before deep diving a bit more into what we're here today, more specifically on around the evidence synthesis and support. So one of the resources, which I'll just spend one slide on, is in the central gear of the whole LHS around patient, family, caregiver, and provider co-design, is we've established what's called the Office for Patient Engagement in Research Activity, or OPRA, website being there, where we have resource staff within this office that really focuses on how patients and caregivers and provider and family members can partner in the whole process, whether it's to support identifying potential patients or people with lived experience, engage them in the study or evaluation design and thinking about training for them, help them to be a part of the process of developing research questions and broader engagement research methods. So if this is an area that might be of use within your OHT, feel free to directly reach out to our OPRA folks within the Method Center. The second gear that I wanted to emphasize is around implementation, which isn't going to be the focus of today's webinar necessarily, but wanted to emphasize that within the Ottawa Method Center and Ottawa in particular, we have a dedicated center for implementation research that assembles 14 multidisciplinary, interdisciplinary experts in implementation science. It was established in 2018, in fact, January 20th, 2018. And you might ask yourself, why do I know that so specifically? Is that on the launch date of our center happened to be the date that my daughter was born. And so that one etched in my mind forever. But what our Implementation Research Center provides expertise in is very specific areas of implementation science, and whether it's leveraging data for feedback to teams or providers, developing rigorous decision aids, evaluating clinical practice guidelines, as well as the methods such as evidence syntheses, qualitative survey, consensus methods, intervention evaluation, barriers assessment, and intervention co-development. And so it's really a deep dive for the implementation cog. Really what we're here for is this evidence synthesis and support. So I wanted to give you a sense of a couple of examples of how our team at the Method Center has been involved in leveraging evidence synthesis that have been requested by government or external organizations, and indeed facilitated by the team at McMaster Health Forum that you'll hear from next. And just give you an example of how leveraging those types of rapid evidence synthesis can be built into the whole LHS process. So the two that I'm going to focus on are what's called the optimized platform, which is our COVID-19 experience, and then I'll talk about the diabetes eye screening Ottawa example. So within the pandemic and facilitated by Kaylin and the broader team at McMaster Health Forum, there were requests coming in from the ministry or the Public Health Agency of Canada around different areas of response to the pandemic. And the expertise that we could bring from an evidence synthesis perspective is rapid responsive evidence syntheses, often within less than a month, to summarize what we know, for example, about what's affecting at the time acceptance and uptake for vaccination in different groups, and understanding risk perceptions, understanding the relationship between mandates and trust, looking at what are effective interventions for promoting adherence to public health and safety measures. And some of these were living reviews, so we would update them every couple of weeks so that we could provide the evidence as quickly as possible to our requesters. And so what we would be able to provide, for example, is even up to earlier on in the pandemic, there was already 175 studies in August 2021 of people looking to see what is stopping or helping people to consider COVID-19 vaccines. And what we're able to do is summarize what is coming through the qualitative and survey literature as this particular example, and then categorize them using particular frameworks to make it easier to digest those 175 studies to make more actionable recommendations going forward. So that's just an example of the kind of expertise that we could bring to an evidence synthesis. And what that particular example provides is, set the stage for, is that we could draw on that synthesized evidence. And what we did was establish what we call the optimized platform, which ended up being funded by CIHR and is a partnership, in this case, with public health units and community leaders in 3 cities, where we are coming in as a team to provide support to the public health units and further developing partnerships with community members that were underserved and not at levels of vaccination targets that the public health units were striving for. And I want you to see this as an example of how evidence synthesis can be linked into partnerships and the specific supports that we can provide. So what the key steps really within this process were that we wanted to make sure that we prioritized underserved groups using data from the public health units themselves. So they determined which groups and which areas we focused on, co-lead with patient and citizen partners, including Maureen Smith, who you've heard from, I think, in the past. Some of you have attended these sessions. Connect with community leaders to reach out to community members to hear directly from community members what is affecting their decisions, and then work with community members to develop strategies that could be brought back to public health units to support them. So what that enabled us to do was we leveraged data in the earlier phases of that learning health system in each public health unit separately, that they specifically identified either areas of the city, certain doses of the vaccine, or certain community groups within their city that they wanted us to support alongside what they were already doing. You can see these examples here. And then that enabled us to engage with community leaders in we developed relationships with community leaders in each of those cities, had a number of meetings that were led by patient engagement co-leads, in some cases in multiple languages, with a focus on trust and cultural and linguistic competence, acknowledging historical injustices where relevant, for example. So these are the types of things that our team can bring to bear alongside in our partnerships. I won't go into the depth of the details on this slide, but what I wanted to emphasize is that by going through this process and community partnership, connecting with public health units to identify those we're able to reach out to people in each of these communities that honestly, I don't think we would have otherwise been able to do had we not gone through this partnered process of community engagement and partnership with the public health units. We also went into this knowing that the public health units were already doing fabulous jobs in the jurisdictions that they're working in really challenging situations. And so what we wanted to do is do our homework to make sure that what we were working on and recommending back as a consequence of the partnership work that we're doing is complementing and adding value, not just repeating what's already been happening. And so this is another piece that we can provide, is making sure that we're using multi-method approaches to get a sense of what sort of strategies are already being used. And we had a process for engaging people with lived experience in the different communities to develop strategies to bring back to public health units, and then develop policy briefs so that they could be digestible recommendations for the busy professionals within public health units. So a more transparent and direct process back to our partners in PHUs. So that's an example, a sort of COVID example. I also wanted to give you an example of a more integrated approach between community health centers, community groups, and tertiary care and hospital programs. So this is the Diabetes Eye Screening Ottawa program. So just quick context around this from a clinical perspective around diabetic retinopathy, very common microvascular complication, one of the leading causes of sight loss, if not detected and treated. Rates for screening are relatively low across Canada, and particularly lower in people that have immigrated to Canada. So for example, in Ottawa, data pre-pandemic, 40% of people had immigrated to Canada with diabetes hadn't had their eyes screened in the last 2 years. So what we wanted to do from an evidence synthesis perspective is do our homework. So we wanted to see, what do we know from the rest of the world around why don't people get their eyes screened? And so we were able to identify 69 interview and survey studies, and then not just identify those, but using particular frameworks to just categorize what are the factors that are preventing people from coming in to get their eyes screened. So a number of different factors identified, and we noted that only 3 studies out of the 69 were in Canada, and only 1 was within a minority group. So that gave us some pause for some future work. And we also want to do our homework, again, with an evidence synthesis around what works to increase screening attendance. So we partnered with folks with expertise, clinical expertise in this, and identified 66 trials that have tested strategies to see how can we get people to come in to get their eyes screened, and then did a deep dive on particular strategies on the right to see what particular elements of outreach programs really help to get people through the door. But we were really interested in that immigration to Canada perspective and working with equity deserving groups. So we took some time to deep dive with 39 interviews conducted in Urdu, French, and Mandarin in Ottawa and Montreal to really get a sense from different communities, equity deserving communities, what were the specific challenges that they faced in coming in to get their eye screen, which all came together to enable us to get some funds to co-develop and establish a new community health center-based telemedicine eye screening program to address some of the barriers, including cost, wait times, access, which was developed as an integrated care partnership between a CHC, Centertown Community Health Center, that hosts our regional diabetes education program, with the Ottawa Hospital Research Institute and Method Center, as well as the Ottawa Hospital Eye Institute. And so we went through a number of processes of co-design through that as a consequence of being able to draw from those evidence syntheses and those primary studies with community members. So we partnered, did a number of co-design workshops in multiple languages, and including health system partners. We purchased a state-of-the-art camera that could be housed at the CHC to enable a task shifting intervention, so that rather than optometrists or ophthalmologists who are busier and less cost effective in this process, and instead having a trained screener based at the CHC to do the screening, upload images securely to the Ottawa Eye Institute for grading and follow-up treatment and care as needed. So that's been a successful integrated partnership within the Ottawa setting, and all drawing on that initial, those that doing our homework from an evidence synthesis perspective. So this is my penultimate slide. It's really just to emphasize with these 2 examples, 1 or 2 of many that we could have flagged, the 2 that I've been involved in closely. But really evidence synthesis and support can provide that foundational perspective that can lead to the rest of the gears in the learning health system. And from the Method Center perspective, we can definitely support you if interested in drawing from some of the state-of-the-art approaches in implementation science in particular, to do things like synthesize barriers to implementation, synthesize what we know about acceptability of new interventions and effectiveness of different interventions. And so if you're interested, I haven't been able to follow the chat because I've been speaking so quickly. Apologies if it's been a bit too quick of a whistle-stop tour. But if you're interested in leveraging any of the expertise within the Method Center that we've talked about, you can put in a service request directly on the website, ohri.ca/Ottawa Method Center. And so that will trigger a triage, and we go through all requests, reach back out to everyone. You're set up with a free consultation to see how we can address your needs, and then work with you to see how best we can support you. If you have a really quick, short question that doesn't need a consult, you can also even ask a question directly on the Method Center website. So do use that resource if you think that can be helpful. But of course, also reach out to me directly if I can be helpful. And I'll leave it at that if anybody has any questions.